Good evening, everyone. My name is Dr. Jessica Peterson. I am assistant professor of maternal-fetal medicine at the University of Chicago. And tonight I will be talking about hypertension in pregnancy. So the objectives of this talk would be to define different types of hypertension in pregnancy, to recognize the signs and symptoms of gestational hypertension and preeclampsia, and to discuss initial evaluation and information gathering to assist in diagnosis and management. So first, we'll start off with chronic hypertension because that is seen not infrequently in our clinic. So what is chronic hypertension? The definition of chronic hypertension would be elevated blood pressures before 20 weeks or outside of pregnancy, or the persistence of elevated blood pressures 12 weeks after delivery. An elevated blood pressure would be systolic blood pressure of 140 or diastolic blood pressure of 90 or higher. We have not adopted the new internal medicine diagnosis of elevated blood pressure, which is 130 over 80. In pregnancy, we are still using 140 over 90. So why do we care about people with chronic hypertension? They need additional monitoring in pregnancy because they have some elevated risk factors, specifically increased risk of fetal growth restriction, preterm birth, preeclampsia, which we will discuss later, and abruption, which can lead to a stillbirth. So how do we manage chronic hypertension in pregnancy? So oftentimes these patients may need blood pressure medication to keep their blood pressure less than 140 over 90. Our goal is for them to primarily be less than 140 over 90, but they do not have to be perfect. And this is where we often utilize home blood pressure monitoring as well as clinic blood pressures to determine if someone needs to start medication or if their medication needs to be increased. Additionally, for preeclampsia prevention, we recommend initiation of aspirin at 12 weeks, and that reduces the risk of preeclampsia. Additionally, because of the increased risk of fetal growth restriction, we recommend periodic measurements of the fetal weight, usually starting at around 28 weeks and every 4 weeks until delivery. Lastly, chronic hypertension can increase the risk of stillbirth. And so that is why we do antenatal testing. In our clinic, we generally do biophysical profiles, but other clinics will sometimes do non-stress tests, or they'll do something called a modified BPP, where they actually measure the fluid and do the non-stress test. All of those things are appropriate, but they do need some sort of testing. And then lastly, we do delivery between 37 and 39 weeks, depending on people's blood pressure control. So if people have very well controlled blood pressures, they've been on a stable dose of medications, then typically we would do 39 weeks. But if they have increasing blood pressure medication requirements or it's not well controlled, it could be as early as 37 weeks. All of these is considered a term delivery. It's just a matter of reducing the complications by keeping the person pregnant, the complication primarily being preeclampsia and the associated poor outcomes. And then throughout the course of their pregnancy, we would monitor them for signs of preeclampsia. So that could be a sudden worsening in their blood pressures, or it could be signs of a persistent headache, new nausea and vomiting, or spots in their vision that persist. And then another kind of hypertension in pregnancy is gestational hypertension. So gestational hypertension has the same blood pressure requirement as chronic hypertension. So that would be top blood pressure 140 over 90. Sorry, systolic blood pressure greater than 140 or bottom blood pressure greater than 90. But it has to be on two separate occasions, at least 4 hours apart after 20 weeks, and someone with previously normal blood pressures. So sometimes you might see someone comes in their first or second trimester with totally normal blood pressures, and then at 21 weeks, suddenly they have an elevated blood pressure and they keep having them. Technically, that person would have gestational hypertension and not chronic hypertension, even though it happens so early in pregnancy. And oftentimes we say 4 hours apart on two separate occasions, but generally speaking, we don't diagnose someone with gestational hypertension if they only have like one-off elevated blood pressure. Typically, we would wait until they are more persistent to give them that diagnosis because it requires such intense monitoring. The reason it requires such intense monitoring is because of the risks of gestational hypertension. So a risk of preeclampsia, a risk of preterm birth, a risk of severe hypertension, which is 160 on the top and 110 on the bottom, and fetal growth restriction. And all of these things can increase the risk of a stillbirth. So you'll see that most of these interventions are really about trying to prevent a stillbirth as well as severe maternal morbidity. So how do we manage gestational hypertension? So when someone is diagnosed with gestational hypertension, we do serial growth assessments, usually at whatever gestational age they're diagnosed with gestational hypertension, no matter how early that is. And then we would do antenatal testing, again, non-stress tests, biophysical profiles, things like that, at the very least every week. Oftentimes, though, for us, we do them twice a week because of the risks. And then we do preeclampsia labs every week, and then we do delivery at 37 weeks. So preeclampsia labs would be liver function test, their CBC, which mostly we're looking for their platelet count, a measure of their kidney function with creatinine, and then you can also do an assessment of their urine protein because that can differentiate, as you'll soon see, between gestational hypertension and preeclampsia. And then again, the rationale for delivery at 37 weeks is to prevent stillbirth, preeclampsia, and other complications. This timing is earlier than chronic hypertension because this complication is directly related to the pregnancy, and thus delivery, in theory, should cure this complication and prevent it from progressing. So how do we determine the difference between gestational hypertension versus preeclampsia without severe features? So this is kind of the middle ground between gestational hypertension and preeclampsia without severe features are conditions that can be monitored as an outpatient setting, but once you get to preeclampsia with severe features, that's when it becomes inpatient. The reason we care about the difference between gestational hypertension and preeclampsia without severe features is because people with gestational hypertension can be maintained usually longer in the outpatient setting and usually don't progress to preeclampsia with severe features for a few weeks, whereas those with preeclampsia without severe features will often progress to preeclampsia with severe features in a matter of days. So over here, you can see the definition of gestational hypertension that I already said. Over here is the definition of preeclampsia without severe features. And as you can see, the only difference is this with proteinuria part. Okay, so that is a defining difference between gestational hypertension and preeclampsia without severe features. So what is the definition of proteinuria? So some of this stuff you guys won't actually see because there are labs that we review. So for instance, if we have people do a 24-hour urine, we're looking for 300 milligrams of protein or more in that 24-hour urine collection. If we're doing a protein to creatinine ratio, we're looking for 0.3 or more. And what you guys might actually see, if I can get my thing to work, is this dipstick rating when you dip the urine of 2+. This is not really our preferred method. And oftentimes if I saw this, it would probably prompt me to do additional testing. But this is something that you might see in clinic as a sign that the person is developing preeclampsia. So what is preeclampsia with severe features? I keep talking about it as this thing we're trying to avoid. So what is it? So preeclampsia with severe features is basically everything in this big box over here. And there's a couple of ways to diagnose it. So the most common way we diagnose it is with severely elevated blood pressures. So usually what happens is someone with either pre-existing hypertension or no pre-existing hypertension suddenly has severe range blood pressures, which would be a systolic blood pressure of 160 or higher or a diastolic blood pressure of 110 or higher. And frankly, if someone persistently has blood pressures that high, that in and of itself is enough to diagnose them, and we would treat them like they have preeclampsia with severe features. But there are other things that can support the diagnosis, such as the proteinuria, that gives you the preeclampsia part, or these lab abnormalities that are listed here. So I talked earlier about preeclampsia labs, and that's something we do to monitor with people who have gestational hypertension. So this is actually what we're looking for, and that's the reason we monitor them, is because if these labs are abnormal, even if a person's blood pressure is not severely elevated, we would still diagnose them with preeclampsia with severe features. So that would be if they have platelets less than 100K, if they have renal insufficiency, which means a creatinine greater than 1.1, or in someone who already has kidney problems, a doubling of their baseline, if they have liver function tests that are twice the upper limit of normal, if they have, and also if they have symptoms like pulmonary edema or they have a new onset headache that's not responsive to medication. So it can be a bit complicated, but what you will probably mostly see is someone suddenly having severe range blood pressures who didn't have them before. The reason that preeclampsia with severe features can be so dangerous is because it can result in organ dysfunction, so liver dysfunction, renal dysfunction, that can take a very long time to recover from. It can increase the risk of maternal stroke, of fetal stillbirth, of growth restriction, of preterm birth, and it can progress to eclampsia, which is what we're ultimately trying to avoid, which is a seizure. And anyone who has a blood pressure problem, whether it be gestational hypertension, preeclampsia without severe features, or preeclampsia with severe features, does have increased long-term cardiovascular risk as well. So this page just sort of sums up all the different kinds of hypertension. So, and it has the different definitions of each one. I want you guys to think of gestational hypertension, preeclampsia without severe features, preeclampsia with severe features as sort of a continuum and sort of representing like a progression of severity of disease. So someone can get gestational hypertension, they can progress to preeclampsia without severe features, they can progress to preeclampsia with severe features, and then they can progress to eclampsia or something called HELP syndrome, and those things are managed as an inpatient. Oftentimes, though, people will come in with perfectly normal blood pressures and then end up with preeclampsia, and that's mostly what we see. So, what are some signs and symptoms of gestational hypertension and preeclampsia that you guys can look out for or ask the patients about? So, some signs and symptoms. So, an elevated blood pressure and someone who had previously normal blood pressure. So, suddenly they're greater than 140 over 90, or someone who you know has chronic hypertension, but generally has well-controlled blood pressures when they come, or kind of low mild range, and suddenly they're a lot higher than they otherwise were. And like I said before, if someone has protein in their urine, most likely what you guys would see is a 2+ protein on a urine dip. And then other lab abnormalities would be the low platelets and the elevated liver function test, which primarily the providers would see. And then if you see elevated blood pressure, some other symptoms people might have would be a headache that doesn't go away with Tylenol, new nausea and vomiting in the third trimester, right upper quadrant pain, or persistent spots in their vision. And this picture is from the March of Dimes. The March of Dimes actually has a lot of information about all sorts of complications in pregnancy, but it has some really good education about preeclampsia and some really good education that for patient facing that can clearly explain what patients should look out for. So, what are some things that you can do in clinic to help their provider diagnose someone with preeclampsia or a blood pressure problem in pregnancy? So, if you notice an elevated blood pressure, what are some things that you could do? Well, you could ask them about the other symptoms of preeclampsia. Have you been having headaches? Are you having trouble breathing? Are you having new nausea and vomiting? Are you having right upper quadrant pain? If a patient reports symptoms of preeclampsia to you, you could ask your provider, oh, do you want me to dip their urine to see if they have protein in it? Or if you notice facial swelling, you could do the same thing in asking them other symptoms. So those are some things that you can do even without, necessarily having the provider ask to help diagnose or kind of triage people to see if they have preeclampsia or some sort of blood pressure problem in pregnancy. And those are my references. And that's my email if you have questions. And I will stop sharing and let you guys ask questions.
While there, thank you, first of all, for doing this. Excellent summary. A good review for me since I haven't been doing OB in a while. But something selfish to my practice, I think that many of the MAs are always in tune to asking about these things during pregnancy. But it's also really important to ask later on, after the patient's delivered, did you have a history of preeclampsia and or gestational hypertension? Can you talk about why that's important that they ask that and make sure they alert the gynecologist that they're seeing?
So the reason that's important is actually, as I stated, preeclampsia, gestational hypertension can increase your risk of like poor cardiovascular outcomes in the future. So like developing chronic hypertension, having a stroke, things like that. And actually, preeclampsia and gestational hypertension have been, I think, incorporated in the new score that the cardiologists are using to risk stratify people for different treatments outside of pregnancy for their cardiovascular health.
Thank you. I don't know, Yasmin, Rachel, Daniela, anybody have any additional questions for Dr. Peterson? You guys see a lot of this in clinic.
Yeah, I feel like I recognize all these names, so I know that
Mhm.
that you guys help us out a lot.
Not to put you on the spot. I mean, she did do a really good job of reviewing. It may not be that you have anything to ask.
No, I personally don't have any questions. I think Dr. Peterson did a really good job answering everything.
Anybody have any common scenarios or things that patients call with that you struggle with asking? I don't know if there's any nurses on here. I know the nurses normally get those calls. All right, Dr. Peterson, you were a rock star.
Well, thank you for having me. I appreciate it. And I put my email at the end, but also feel free to grab me in clinic if you have questions. I'm happy to answer questions.
Thank you so much.
Thank you.
The
Bye,
next
Dr.
evening
Peterson.
rounds is going to be Dr. Ken Noons again on June 1st. So hope to see you all there.